I do want to move to Q&A because we do have some questions, and I know that's patients' favorite part. Dr. Thorsteinstatter, let's start with you. There's an anonymous question that says, do you collect the stem cells of smoldering myeloma patients before they become active myeloma patients? I don't know if that's specific to the iStops study or just, in general.
Well, the patients that are included in the clinical trial and are receiving treatment that want to participate in that, they are offered stem cell collection, yeah.
Okay, great. Okay, Georgie is asking a question that has to do with high risk, so I'm not sure who wants to answer this one, but I'll open it up and you can jump in. I have high risk smoldering myeloma, but also have a RUNX1 FPD variant that predisposes to AML. So lenalidomide can help contribute to causing AML. I've been advised not to take it. Is there any kind of substitute if you're a smoldering myeloma patient and you want to start therapy? Because a lot of those potential lines include lenalidomide, right?
Can I answer that?
Yeah, sure.
So the currently outside of clinical trial is not recommended to treat patients with smoldering multiple myeloma. That's what is written on the books. Then I think that one of the key message from the Icelandic study, just to comment someone else data, is that the diagnosis of multiple myeloma in monitoring this patient early can be done, and that's obviously would avoid symptoms of organ damage. So the idea of having high risk is not to treat them, but to monitor them. Also because we don't know really high risk what they are. Again, there are 3 different scores and the concordance is pretty poor. So is that because all scores are good, we need to combine them, or because they are all bad? Probably like in the middle of the two. But the idea is that lenalidomide single agent, I think we don't have enough evidence despite one single paper to provide this. And I believe that high-risk smoldering, and we published that already, are multiple myeloma, as you said before. They are just myeloma that are expanding. So it can take 5 years, 2 years, 6 months. They already multiple myeloma. They have everything they need. It's just a matter of time. So if you want to treat them, if you really want to treat them, you need to treat as a myeloma. I don't think lenalidomide single agent right now. It was a great idea when the trial was designed, but right now we have daratumumab, Revlimid, carfilzomib, like we have drug combination with such an amazing result. So I think it would not be great to actually do that.
So you basically be under-treating a high-risk smoldering myeloma patient that's probably just how it looks like they have active myeloma. You know they're gonna have active.
If you want to treat, if you see the disease progressing, and obviously you don't want the patient to get a fracture or pain or kidney failure, so you want to treat them early, and I totally agree with that. But I believe you need to treat as a myeloma. And so, like, our group published a KRD in high-risk smoldering with 70% sustained MRD negativity at 5 years, or there are currently trials with daratumumab, RD, ongoing. So, but I think it's the same disease. So why you want to not treat a tumor in the way in which you would treat with symptoms? Actually, the patient is in better position because doesn't have symptoms. So
right, before you have organ damage, just get it done. Yeah, makes sense.
I think these are all very good points. Well researched. I know that this is an area with a lot of active debate. You'll hear very strong opinions from all sorts of different sides of this. You'll talk to one person who says, we need to be treating everybody with high-risk smoldering. Some of them will say with, lenalidomide plus or minus dex. Some, like Dr. Mara will say, this is myeloma, just treat it like myeloma. And we are understanding more about this all the time. But in order for us to really know what the best way is to do this, because I wonder, even if all of the genomic abnormalities are there that give a plasma cell the ability to invade and cause the symptoms related to myeloma, perhaps there are still some of the immune microenvironment signals that are preventing it from doing that. And, that's kind of the concept behind lenalidomide and why maybe it could be reasonable in that sense. But I don't personally treat smoldering myeloma outside the context of a clinical trial. unless it's a very extensive conversation with the patient, with the pros and cons, and somebody who really can grasp all of these details. So I would say, you know, I personally would recommend, if you're thinking about treatment, do it as a part of a trial, because we need to understand this better when we're treating precursor conditions, at least in the United States. But the other thing, you know, I believe that there was a paper that came out from Dr. Gobriel's lab about CHIP mutations, like the RUNX1 mutation, you know, and outcomes with, you know, lenalidomide maintenance or transplant. And I believe that there may have been higher risks of leukemic progression, but that these patients still benefited from all of these and the interventions aimed at treating the cancer that one already had. So I don't know that I would say that needs to be the one factor that is kind of determining what the best treatment approach is for this individual, but it is something important to keep in mind when considering whether to do lenalidomide treatment.
Are there any smoldering myeloma trials for CELMoD at this point, or no? There are? Okay, I didn't know.
Yes.
That might be an option, right?
There's a study through ECOG open kind of across the United States looking at lenalidomide plus dexamethasone versus Lendex plus daratumumab for 2 years, looking to see if limited duration treatment with a myeloma type regimen or a smoldering type regimen, you know, not only prevents progression, but improves survival. So that's open. I believe that there's one looking at iberdomide, which
that's what I was asking about.
better tolerated. But these are only one type of trial. There's so many out there.
Yeah, we have trials that, you know, in Miami, we're going to open soon a trial for high-risk smoldering. If, you know, patients are interested, they can reach our clinic. But yeah, I think what is really important, it's that, as Sigurd said before, is smoldering and MGUS are concept developed in the 80s. 1980, Bob Kyle pioneered the definition, and that time was like a monument. But now that study was at like 20 patients. So we are still using a classification of 40 years old based on 20 patients. So our group, I think, is one of the few, if not the first, that is trying to say that there are no smoldering. There is myeloma or early myeloma, like myeloma without symptom, but it's already myeloma, and benign monoclonal component. We can find the name or the coolest name. We will set some pool around, but the idea is that one is benign and never progress. Period.
I think this is one of the things that they wanted to do with the flow cytometry study, Bruno Paivo, Spanish group.
The issue with the
MGUS-like group.
Yeah, the issue with that is that you get very well the smoldering with MGUS profile. Also, is fantastic. I mean, Bruno is great in this. He's probably the best. And that means that patients that have smoldering myeloma, you downplay them to MGUS, right? But what you don't see with that, because you don't have enough cells, is which MGUS are actually myeloma. The whole point of this new, what we're trying to develop as a new classification, is that it's not just disease burden, it's not just having 10, 20, 50% plasma cells, it's having genomic myeloma or not. And because we said in our papers, and we believe that myeloma starts decades before, that's the opportunity. We need to define this patient early, then whole genome sequencing, target sequencing, flow, whatever works and whatever is affordable by the healthcare system. But I think we need to change this concept of smoldering and MGUS and try really to understand who is cancer, you know,
But you're still including patients now in trials where you're treating smoldering myeloma, and you're using risk scores that don't really make sense. I mean, the one study that we had that showed a overall survival benefit in smoldering myeloma was the old Spanish study that uses the flow cytometry and immunoparesis, And that was before new myeloma criteria, so it's probably not the same cohort as we have today. And then we used the 220, or we have other numbers here, but
Yeah.
2020. And when we look, and in our smoldering cohort, there is 55% agreement between these two models. So they don't really stratify the patients.
Yeah, absolutely. I agree with
Yeah.
you. The current model are okay. I think that the patients with high risk, with the Spanish Petema risk score, with the Mayo Clinic, all the new scores, most of them are real high risk, but not all of them. And there is a lot of discrepancy and you know,
but I think we need to do a more like a dynamic risk score where we look at the values at different time points and see which way it's going, because if you have stable disease over several months, you're not going to.
That's the other point, that these trials say we treat high risk, but you cannot really say high risk from one evaluation.
No,
you need,
I think that's really important.
Evaluation over time to really say that that's kind of a real high risk or not, in my opinion. But then regarding also what you just said, I think it's absolutely true. We need over time, but think about the patient with the 10% 0.1 plasma cell in the marrow. So it's a smoldering. So it means that he needs to be followed over time. And you want to, you know, check every 6 months. And he has a smoldering myeloma. You go on internet and he say, oh my gosh, 10% risk progression every year. And I'm 50 years old, which means that at 60 years, I will be progressed for sure. You know, that's what is written. You go everywhere, you find this, right? Mm-hmm. If you don't have the right statistical skill, you obviously believe what you read because it's lay language. And that's what concerns people. And like my neighbor, he's so concerned about his MGUS. And I told him, how long have you been with MGUS? Oh, a long time. So don't worry. That's not going to affect your life, probably. I mean, the chances are very low. But that's the whole point of predicting early. It's not just spending money for research, but if you really can say, look, you have something bad that we can check over time. There is no need to treat now, but we can check. And in other patients, most of them actually, you say, don't worry, just go to the GP one time per year. And if something moves, come back. You can say that with confidence. That would change a lot in patients' life, right? I mean, I'm checking my mark on the skin every year, right? For melanoma. That would be the same.
But I think it's really important that what you're saying, that the ones that are truly not going to progress, we need to think about that. We're not telling them that they will get a disease that they will never get. So that's really important.
Yeah, the mental factor for patients is key as well, right? So the more we can do on identifying risk and risk of progression and all that is very mentally helpful and emotionally helpful for the patients. So yes, totally. Okay, so Dr. Schmidt, maybe you want to answer this question. For the 1Q population, have you seen any treatments that are preferable or more effective? You were saying transplant, stay on therapy, right, before? Mm-hmm.
Yeah, so that's a really great question, and one that, you know, I think the answer is somewhat complex too. I would say most of these treatments are working very well for patients, whether they've got chromosome 1 abnormalities or not. The question is durability. And, you know, how are we going to promote a long survival for patients with these abnormalities? It's not necessarily a question of whether it's going to be a response, but the durability. And, you know, one of the challenges with 1Q is that this was not a variable that was included in the collection of data for a lot of clinical trials for a long time. So we don't really have a ton of information about this. What I would say is that, you know, just looking across studies, I think transplant is an effective treatment. The Forte study, which was an Italian study, a phase 2 looking at carfilzomib-based induction with or without transplant, showed that patients with gain1Q who got a stem cell transplant did basically just as well as those patients who did not get a stem cell transplant when they got KRD induction. So I don't know if I said that exactly right, but a transplant seems to be effective in terms of promoting that longer term survival for patients with gain of 1Q, maybe this intermediate stage of risk. But, you know, for AMP, it is somewhat challenging. And I would say that, you know, investigational approaches, we really need to be looking at that. Regarding daratumumab, which I think is the other kind of, or CD38 monoclonal antibodies in general, that's the other, you know, consideration here. The Griffin study, which looked at DARA plus RVD induction followed by transplant versus just VRD, the patients with 1Q abnormalities did seem to benefit from the addition of DARA. It's just a little bit too early to really see survival from that. You know, I would say we have to make the best decisions that we can at a certain point in time. I think that, you know, adding in daratumumab would be reasonable if you've got that, but definitely transplant and being more vigilant to look out for it if it's feasible is kind of what I would recommend. Moving towards the future, I think that, you know, there's a lot of potential targets on chromosome 1Q that are going to be looked at, but this is all still investigational, and hopefully we'll, you know, learn more about that.
Okay, great. Okay, Dr. Mara, you have a request to post a poster link, if you can, by Benjamin Diamond into the chat, maybe.
I think this, yeah, I can post it.
And then the question is risk on bispecific antibodies for relapsed refractory myeloma. There's a question about cevostamab potentially developing lymphoma. So are FcRH5 or GPRC5D different targets than BCMA for these new bispecifics and CAR-Ts? Are they more dangerous for the developing like a secondary blood cancer than this BCMA target? Great question. I've never seen that question before, but I think it's a great question.
Is that for me, right?
Yeah, you can take a stab at it, and then everybody else can weigh in if you want.
Yeah, so the abstract from Benjamin Diamond we presented at ASH is actually posted, but I actually thought was our best abstract over the many we submitted. And the reason is that we show that the therapy-related myeloid is known to be increased in patients receiving undergoing transplant in myeloma, and not just myeloma. And historically, this has been linked to the genotoxic effect of melphalan on the DNA. So that's what you read in the book. What we show is actually, we demonstrate in a very complicated way, but it's kind of extremely robust, that most of the patients that develop therapy-related myeloid malignancies after transplant, the clone that will, you know, transform in these leukemias is actually reinfused. So it never been exposed to melphalan. It just skipped the melphalan, it got through the apheresis and go back. So that means that melphalan genotoxic effect is not so important because most of the patients don't even see that. So what is important probably is the immunosuppression that melphalan provides. So these tumors, this pre-tumors clone expand through the immunosuppression. So that's the concept, I think the new concept of the study. Then for the bispecific and CAR-T, I think for the bispecific, we don't have much data. But for the CAR-T, it's kind of, for myeloma, we don't have a lot of data, but for lymphomas where they use CD19, if the patient survived, and half of the patients survived with large B-cell lymphoma, you usually don't recover the B-cell forever because the CAR is still around, the memory response is still there, and you will be immunosuppressed for your entire life, more or less. So that's obviously great. You survive a disease that would have killed you, but still you have some problem to take into consideration. And what we suspected and what has been presented at ASH, I don't remember which group, I think was a collaboration between multiple institutions, is that 10% of the long survivor with the CAR-T, CD19, develop secondary tumor, which is super high.
Yeah, very high.
So that's obviously is a matter of these patients were treated before with platinum, it's then CAR, and you know, a lot of bias needs to be corrected, but still it's very high. Obviously, it's again, would I prescribe CAR-T? Yes, 100% without any doubt, because what you need is to cure the tumor. But then you need also to monitor. We need to understand what happened after, and that's, you know, some of the things we discussed today.
That's so fascinating. Okay, well, that makes me a little alarmed, but so things to watch in the future. Kenneth is asking this question, Dr. Thorstein's daughter. Can you answer this maybe? Any comments on overall genetics of myeloma, risk to children? Should kids be screened? We get this question a lot.
Well, based on, we haven't investigated this in our cohort yet, but we will. But based on Swedish data where they have looked at first degree relatives, there is a little bit increased risk, but it's very little. So we don't recommend screening first degree relatives.
Okay.
So, yeah.
Okay, I know the PROMISE study is screen. Well, no, they
the PROMISE study.
Yeah, the PROMISE study is screening family members, but only over age 40. So that would be helpful because there is a slight higher incidence, right? So if you're interested and you have family members that are over 40 and you're a myeloma patient, you can invite them to participate in that study as well. Okay.
But because
because
myeloma is a rare disease, so even though you have a little bit increased risk of it, it's not high enough that we recommend screening. But of course, the PROMISE study will investigate this further. Yeah.
Okay, Kathy's asking if you can say something about the 1Q gain in IGH rearrangement.
Yes, so 1Q gains can be seen basically regardless of what other IGH rearrangements there are. Or if there's no IGH rearrangements, they can happen basically in any myeloma clone. There's perhaps some suggestion that when they occur in these patients who have IGH rearrangements, that the biology of it might, have something to do with, genomic instability and, some sort of aggressiveness there, but we don't really know all the details. And I hesitate to say any specifics necessarily about this, but particularly it seems that if it's combined with a 414 or a 1416 translocation, these other high-risk genetic abnormalities, that when we start to stack up some of these high-risk features, that does tend to indicate perhaps something that might act a little bit more aggressively, and we might want to think about something, a clinical trial early, or something more aggressive.
I think you're muted.
Jenny, I think you're muted.
Yes, sorry. I'm coughing, so I'm still recovering from COVID, trying not to annoy everyone. Let's talk about deletion 17 generally. Anne is asking about her husband's situation, but you kind of mentioned that it's not always high risk, so let's not freak everybody out and tell them that it is. I know I've heard from the COMPASS study data that having both alleles missing is considered more high risk if you have the TP53 mutation. So someone else was asking lower down in the chat if should we be screening for this TP53 mutation every time you get a biopsy? Do you just want to address deletion 17 generally, so we have a little more clarification around that?
Yeah, so there are few papers showing that deletion 17p alone it's not prognostic unless you have TP53, and that's what is called double hit by Garrett Morgan group the first time this concept was developed, but different groups found the same. So when you have different groups showing that deletion alone it's not prognostic, which means it doesn't affect the outcome, while deletion plus mutation is actually what affects the outcome, like it's kind of established. You don't need to do more. There are at least 3 independent groups and papers, not just COMPASS, showing that. So one is COMPASS, one is MRC11, and one is the French Dana-Farber-Sanger collaboration that we published in 2018. And all that the studies pointing in the same direction. The same extra 1Q gain, having 4 copies versus 3, that's established. So the fact that we don't use this in clinical trial, it's not because we don't know, it's just because it's hard to change your standard behavior after 20 years of doing the same. That's just what makes always difficult changes. But yeah, yeah, so I think that's summarize my point about vicious ATP, why we should monitor or not. So that's another question. And I personally say during my talks that in 2022, we should stop to do fish once for all, forever. Let's not talk about it anymore. And clinical trial, they should just say, FDA should say, we don't accept fish anymore. We just replace with NGS. It costs half. It gives you much more information. You get all the copy number, you get the hyperdeployed, you get the mutational TP53, you get the double 1Q gain. It costs much less, it's more informative. Why we don't do that? It's like I had to go from Miami to Tampa and I have a bicycle and a Tesla. I mean, of course I want to use the Tesla. Why should I keep using the bicycle because FDA say you have to use the bicycle? Let's convince FDA that Tesla is better to drive from Miami to Tampa. So unfortunately, I don't have a Tesla, but the concept is that we really need to change this. And it's kind of, for me, is every time I see this presentation with fish high risk, and then they put this hazard ratio that works in high risk. Of course, these are not high risk. Of course, all the drugs work in high risk because these are not high risk.
It makes sense.
Change this concept.
Yeah, and when I was diagnosed in 2010, you know, I was just kind of asked in a very large patient meeting how many patients had had genetic testing at all done. Less than 10% had. And the doctors at the time were saying, well, it doesn't really change what we're going to do. But I was like, well, that's kind of not the point because you don't really know what you started with. So wouldn't more information be better? And then, you know, 10 years later, we're like, okay, genetics are really important. So let's just gather the most information that we can and go from there. I think Jade has a really interesting question because you talked about the master trial and how effective it was to have this quad therapy upfront in newly diagnosed patients. For patients who did not get a 4-drug induction, had stem cell transplant, should daratumumab be added to maintenance? That's an interesting question because I know it can cause extra infections and things like that. So how do you balance that? Or what do you think? What do you say to that? Should it be added? Dr. Schmidt, do you want to take a first shot at that? And then
sure. Yeah, no, it's an excellent question. In terms of the relative benefit of, you know, daratumumab versus not, and whether or not we should add it into maintenance therapy, it's such a difficult question to answer. And there are studies going on right now trying to answer that. That being said, the answer to that question is probably going to come many years from now because maintenance studies just tend to take a long time because many patients after transplant on maintenance go a long time before they progress. And so it takes years really to see whether or not an additional drug really provides a whole lot of benefit. I would say that we basically have to extrapolate from some of the clinical trials that we've used to see whether or not adding it in later is beneficial. I would say that probably the one that's the most informative right now is the Cassiopeia study. This is something that was done primarily in Europe, where they compared Velcade, thalidomide, dexamethasone. So not Revlimid, but thalidomide, which it seems to have similar efficacy, but a lot more side effects. And then the study arm, they also received daratumumab in combination with that. Patients received either of those arms, got a transplant, 2 cycles of the same 3 or 4 drug regimen afterwards. And then there was a second randomization to either observation or daratumumab maintenance. And there's lots of debate about the study design for this study and whether or not it should have been designed the way that it was, whether the schedule of daratumumab was the right thing to do in maintenance. But essentially what this study showed was that patients who got daratumumab at any point in time during their therapy had a longer progression-free survival. It did not show a longer overall survival. It's still too early really to see that. But PFS was improved with the addition of daratumumab either before transplant or after transplant. However, patients who got dara as a part of their upfront regimen really didn't benefit at all from it in maintenance. Now, again, I think the devil is in the details here because this was single agent dara at a schedule that is every 8 weeks, which may not be as effective. But I think the other caveat to maintenance therapy is, what is our goal here? Is the goal just to improve time to progression, or is our goal to make people live longer and live better? And I think really the gold standard for adding something to maintenance therapy is to show that it improves overall survival and or quality of life, and preferably both. And I think that, you know, in the absence of data to show that daratumumab does that after transplant for anybody, it's hard to recommend that it be added just kind of across the board, just because it might help to improve time to progression. But I am interested in what the others think as well.
Yeah, and this question is kind of in context of 1Q gain maintenance, like what's optimal. So yes.
Yeah, we don't know.
Yeah.
That's the thing, is we don't really know. And we know that patients with high risk disease, however we want to define that, are less likely to go as long without progression compared to those without it. But making a decision on an individual basis is always so much more challenging, because there are a lot of factors to consider here for an individual, and what that person's goals are and what's most important to them. These are more important questions for us as researchers to figure out how are we most likely to help improve outcomes for everyone. And so I have, you know, been a proponent of adding a proteasome inhibitor to maintenance therapy for high-risk disease, although there's no data to say that that's really helping in patients with 1Q gains. So we really don't know. And I think that you have those discussions with your doctor about whether or not that's something that seems to make sense for you, and make the best decision that you can.
Okay.
I think this, sorry.
Oh yeah, go ahead, Sarah.
Go ahead.
Just short that I agree that we cannot make this decision if we don't have an overall survival benefit. And I think we need some more quality of life data. And I think at ASH, it wasn't very present in the presentations. So I think we are kind of lacking more attention to the quality of data, quality of life data in the clinical trials, especially for things like this that will cost a lot for the healthcare systems, and probably maybe make the patients sicker, or feel that they have to go to the hospital regularly, rather than just living their life without meeting us at the hospital.
Yeah. It's a tricky balance in trying to figure out what's best for each individual patient. I know we're at the end of our time, but I want to ask just 2 more questions, if that's okay. John is asking, we haven't talked about this translocation at all. Where does venetoclax fit in the 1114 patient today in light of prior toxicities in other myeloma patients that they saw in earlier studies? And then we'll have one more question after that. Who would like to take on 1114?
Well, let's say that the venetoclax is a great drug for a fraction of 1114, not for all. We need to understand which cases within the 1114 group are the ones that are expected to respond. There are data under development from Calgary's group, from Emory University published a beautiful paper on blood. We published a paper on clinical cancer research, and all the investigation point to the fact, for example, simple biomarkers. If you have 1Q, 1 copies or 2 extra copies, it's unlikely you will respond to venetoclax, because MCL1 is overexpressed, and we know that MCL1 overexpression, a gene on 1Q, is one mechanism of resistance to venetoclax. But these investigations are just in vitro or with few cases, so we need to access to clinical trial data to really test this model and to really identify. Now, unfortunately, clinical trial, the leaning was kind of, maybe I'm too harsh, but the book how to not handle target therapy, because if you have a target therapy, you just treat the patients with the target, not every patient. But I believe that venetoclax is a great drug and should be much more explored biologically and translationally, because I believe some patients will definitely benefit from it, but not all 1114. It's not like a magic drug.
Yeah, I agree. I hope it gets approved soon because it just seems like a lot of patients could benefit from that drug who have 1114. Okay, last
I
question.
absolutely agree. Oh, go ahead.
Yeah, no, go ahead.
I was going to say absolutely. I think that 1114 is the best biomarker that we have today for venetoclax activity, but dependency on the BCL2 pathway is really what matters, and that's what's been shown by multiple labs, including that at Emory. But when venetoclax works, it really works. There is no doubt that it's an effective treatment for a subset of patients with myeloma, and I agree. I hope it gets approved.
Yeah. Okay, last question. This is kind of more a broad genetics question. Once you have a chromosomal abnormality, do you always have it? So first FISH test showed a high risk feature, had treatment, most recent bone marrow biopsy detected nothing on the FISH. Does this person still have high risk disease?
So the provocative answer from me is, if you finish your induction and you are currently maintenance, it means you are not a real high risk. Because the real high risk don't complete maintenance. 10% of the COMPASS patient progress during induction. 10%.
Oh, really?
So there are real high risk patients, and then there are patients with high risk features. That doesn't mean they are high risk. That's a big difference.
Okay, that's.
If you respond and you are in CR, you don't have the translocation or the deletion because it's difficult to see. You don't have tumor cells that can be detected. So it's just absence of the tumor, not that you lost it.
So you could have killed that particular clone, right? During that therapy. And
so my experience with this personally is that even, if we have completed induction transplant, we see even MRD negative remissions. If somebody does still progress at that point in time, almost always those cytogenetic abnormalities that we would call high risk are still present. If not, there being extra ones there. And usually if we can't find it, it's just because we don't have the available information to see what might still be left over. We just can't detect it with the technology that we've got available, but that doesn't necessarily mean that it's gone. We hope that it is. And I think that, to Dr. Mara's point, the highest risk are not going to respond for long enough to get into a state of remission. But this exists on a spectrum. And I think that to answer the question about whether something was there at diagnosis, if it's still present afterwards, I think that usually that answer is yes.
So you probably still have it. It's just maybe hanging out there somewhere. And you're looking for maybe rate and rise, and you're looking at MRD status, you're looking at imaging, you're looking at rate of progression and all that to determine.
Yes, it's becoming more complex as we speak.
Yeah, so you're looking at a lot of factors. Okay, well, we have more questions, but unfortunately we're out of time. So I would just like to thank you all for joining today. We are so appreciative for everything that you're doing. We're very excited to watch your careers progress and what you learn. We would love to contribute to your research in any way that we can with the data set that we have. Just kudos to you for what you're doing with your studies, because they're just so important. So Dr. Mara and Dr. Schmidt and Dr. Thorsteinsdottir, thank you so much for joining us today. We are just so appreciative of you.
Thank you. Thank you
so much.
Thank you very much.